physicians and clinical workers don't stay in practice for 40 or 50 years anymore. They move on. And the data clearly shows that they gravitate towards more populous dense areas. And so that still leaves 20% of the population out. And that 20% of the population's cancer incidence in quote unquote rural areas is much higher. And this is where AI has to be embraced and where the opportunities are, especially in combination with telehealth.
Welcome to AI in Healthcare. My name is Dr. Sanjay Juneja. I'm a hematologist and medical oncologist, also known as the Onc Doc on social news media. And today we have someone that if you haven't heard of, you surely live under a rock. He's a good friend and also the founder of Bridge Oncology, one of his many ventures through his career. So it is with a warm welcome and excitement that I bring my friend, and surely probably yours, Jordan Johnson. Jordan, it's good to have you here.
Man, super happy to be here. We've been meaning to do this for a while, and it's like we finally nailed it down. So super happy to be here.
I know it. And I think you're my first fellow Louisianian on here.
That's it.
By a hair. Jason Hill.
I still hold the 318 number. The 318 number is still there for Louisiana.
That's it. That's the way to do it. So Jordan, I learned so much from you. It took me a while to even know what you did professionally, just because you speak on several different things. And I think if anyone's listening right now, the couple of things that we're going to hit that you know really well are, one, legal things when it comes to data, interoperability, when it comes to claim data, payer stuff. How do we make sure that people in the community get the care they need? You know about interoperability in general, you know about radiotherapy, and you're a very big policy and advocacy guy. So it was hard for me to kind of pin down what I wanted to start with, but I thought of something unique. And that's a word that I think maybe we throw around a lot and everyone just assumes we know what it entails in its entirety. And I think it's a little more complex than sometimes the way that people use it colloquially. So with that said, when we use the term interoperability in oncology, specifically in healthcare, really in general, what are we talking about and why is it such a big issue?
So I think to your point, when I hear the word interoperability, it carries such a broad connotation. And even in the subsector of oncology, it carries a broad connotation. So is it interoperability among staff? Is it technology? And if it's technology, that opens up a whole different bucket. So is it interoperability from a system between two systems? Is it interoperability between an EMR and the physician? Is it a third-party software? And what does that look like? So I almost think of interoperability as the pipe framework of connecting various things. And then what are the consequences of connecting some of those things? What happens both upstream? What happens downstream? So I think you bring up a good point, is what does it actually mean, interoperability? And it's when two things, in my mind, I kind of simplify it, but can coexist to create something that is either better, easier, bringing more information faster, and accurate. And that's really interoperability between systems in the context of oncology.
100%. And, as a clinician, I first always thought of it as the interoperability of just EMR to EMR. Like, can I access the same stuff that my primary doctor is documenting versus the GI versus whoever I'm, working with? But then I've learned over the last couple of years that it's also data interoperability and data elements. So it's not just the EMR that's an issue, but the data itself that lives, yes, inside of it, but also outside of it. And the way I kind of think about it is, maybe loosely is may not be a good example, but it's really just like using currency in a different country. It's like if you have US dollars in your wallet, you are not broke if you go to another country, but you're not able to necessarily make utility of or purchase the things that are desirable, not because you don't have it, but because you don't have it in the right capacities. And then maybe a step further, which I know my cousins that live in Europe would cringe a little bit, but then you have something like the euro, where the euro can be used in places that do or don't potentially have other currencies. So with all of that said, it's easy to think about how there are a lot of inequities and possibly spillage when it comes to the kind of economic toxicity we have in healthcare that really come down to an interoperability problem. And
It's
can you tell me, let's make people appreciate how much loss and bleeding there really is because of an interoperability or operability issue.
Oh, it's spillage all the way to disparity, right? At both ends of the spectrum. And it's because, and that's why, the government, CMS, they're all pushing for some form of standardization. And that's what happens when we don't have a standard pathway, a standard a connection. That's exactly what happens. So much gets lost or unaccounted for in translation. And whether it's payment data, whether it's cost data, whether it's, and I think about this in pharmacy context, with formularies always changing and things changing. What if you miss that interoperability and the information changed over here, but it's facing you as the provider? You don't have that. And so you have no way to update. You have no
Oh,
way to
wow.
know it's current.
Like a mismatch on the cost of something to the patient, or even necessarily the
Absolutely.
dosing or the formulation you're supposed to use.
Absolutely. Absolutely. And it's massive because there's so many pieces. It's clinical workflow. It's, front end work. It's actual clinician, what the clinician does. And all of those, the level of mismatch potential for the data not being there is huge, and it costs millions and billions. Now there's a lot of companies that would rather there not be standardization, right? So like Judith Faulkner's pumped. She's like, Epic and standardize it and let's go use our system we're already in. But that's also that third party network is what's created so many different companies, as they may do it 10 different ways, and to try to arrive at the same point. uh, and what's an acceptable amount of loss in that data once you get to that point?
So you're telling me even the cost when it comes to a major, payer like Blue Cross or United, they're actually having to go and try to access information to not stick the patient with a bill that they believe was unjustified due to not having interoperability between just simply what is being done and what they're seeing.
Oh, absolutely. Absolutely. I mean, that's what spilled out this whole 5 years ago when CMS required, like, the price transparency. That's why this is so big now, is people want to know, not just how much something costs, what's covered, what am I paying, but why is there such massive disparity even across town between two locations?
Oh.
So if I get an MRI, it's the same MRI, it's the same doctor reading. Why is the price so different? And I think that's really been a push, and it's 100% data, to make sure that it's interoperable with these systems. I think a definitive data basically they collate all this data, payer data, what's been paid, what's been charged, and all that goes back to our procedures, our drugs. Why are they so different? Where is there a level set? I shouldn't see for some of the exact same things, even based on location, we should see slight differences, but to see a huge difference, in a swing or a gap, is how do you account for that? And so those are the questions that are trying to be answered with the data right now. And the data is revealing things, I think, we probably all knew. Maybe the payer rate is better in a certain area, that kind of stuff. So we're seeing some of that kind of spill over now.
And how did we get here? Is this just a product of a capitalistic kind of setup? Not that that necessarily is bad, but is it just that things got propped up as they got propped up and there wasn't a monopoly or
Well,
wasn't an established source? And therefore, is that just where we are? And can we unwind that?
I think you can, right? But the thing is, it made sense when things weren't visible, right? Or we couldn't
Uh,
see it. And so then it made sense. Like you said, things kept getting propped up, and nobody, unless you knew the data, you didn't really know what questions to ask. You just had a lot of assumptions. And now we know some of the data, some of the disparities, and people ask those questions. And that's what's going to cause the unwind, like you said. And yes, absolutely. I think some of it does have to unwind, especially what we see on the drug and the pharma side. I think we were in Vegas this last week, and we had our keynote was a mom and dad that had their son. Son was an asthmatic, got his first like big job, 22 years old, was on Advair inhaler, and it was $55 a month. It had dropped off formulary for the pharmacy. Nobody let the pharmacy know. but the son had gone to pick his inhaler up, and it was $650 from 60, and he couldn't afford the inhaler, obviously, right? And so he had an asthma attack 3 or 4 days later, was in a coma, ended up passing away.
Oh
How
my
did that
gosh.
data, how did that data bypass that, that wasn't communicated to him or the parents, that this is the change, or why is it not covered anymore? And so again, that was all a data-driven situation, but now we can see that stuff, and kind of the ugly side rears its head of, we want some accountability and some answers for this. So it will unwind. I think it's going to be painful, but we'll get back to um, kind of a more, I guess, a reset.
Streamlined and
Yeah, realigned.
yeah. So tell me, so why you say we can see it? Why can we see it now? Like, is it cloud services? Is it exchanges, QHINs? Like, what is the reason we're able to kind of watch it happen rather than have these point cases?
Absolutely. So I think it's exactly that. All of a sudden the data is um it's collated, it's cleaned, it is structured, it is everything that we've lacked before, right? We always underappreciated the power of the basic Microsoft Excel, but really that's where it all started was how many leading zeros are there? I can't see the leading zeros. First, I have to structure the data to then make sure I'm comparing apples to apples. And so much to that through AI and RPA has been automated and standardized that now we're able to see things closer in real time. So what used to take months and years to do to get results and actions from the data now takes seconds, minutes, and we can see.
Ah, I believe that's what our buddy Rajiv Rananki is working on too, right? Like
Abs-
a basically an interface where you can kind of see things in real time rather than kind of Morse code. And I might be saying that loosely, but something to that effect.
Well, I mean, it's huge for clinical operation too, right? And I think about the original oncology care model, the OCM back in the day. And the issue was I didn't get my data until like 6, 7, 8 months later. How am I supposed to make any adjustments or changes? Like I need to see something in much closer real time to be able to account for some of the changes.
No doubt. So this is a whole different kind of slowness or, that I don't really think about when we talk about quote unquote the system slow, like even on this technical data kind of, operation side that you're very astute in, it's easy to appreciate and hopefully something we can hold our breath and not pass out with, to think that it should get better faster than it has backwards. So you'd mentioned AI and saying that could actually help us in that kind of process of making things streamlined. I was reading, and we'll talk about both sides. I think it was in Super Agency, Reid Hoffman's book, that one of his chapters he suggests don't think about all the things that can. I mean, you want to think about the things that can go wrong when you're introducing new things and infrastructure, but don't forget to think about what are the things that could possibly go right and not just possibly wrong. So for a second, what are some of those things in addition to what we already discussed that you get excited about that AI is able to do and improve and ameliorate for the healthcare system that otherwise were very kind of sticky or problematic or even, economically toxic?
For me, it's the level of focus factor. Once we can get the context down, it's the amount of time that clinicians, admins, everybody was spending on just digging into the data. And now with AI, what we would consider some of those um, mundane or redundant tasks can now be completed faster and then given to whoever needs it to make the context call. We're used to it was them doing that, doing everything from A to Z. And AI has the ability to speed that up, to cross check it, to look in other areas. If we're talking about the EMR, to go into other areas and grab what's important. I may have a 10-page E&M note, right? And I only need a certain pieces from that E&M. And the fact that it can go in and grab that quicker, and there's, follow-up notes and that stuff I need from one patient, and it knows what areas to grab of that note and then bring it together, compile it, get it to me. That's hours before that a physician was having to take their time. And now if they can clean that up into 15 minutes, they can now see more patients. They can serve more patients. And that's huge.
That's huge. Is there, off the top of your mind, is there an example country or system where there is this kind of homogeneous, free-flowing interoperability that is ideal? Or is that something that's kind of inherent to, systems everywhere just because of the evolution of the system?
I think it's inherent I mean, I don't think anybody has it figured out. And I also think if they do have it figured out, you can't cookie cutter and then apply it to somewhere else because their variables, their structure, their system, their laws, their finances, the way that things move, that's all different, and all that has to be accounted for. Because if the government says in one country, this is what we're doing, this is the only system, we're rolling it out countrywide, versus you come to America and it's like you have choices of systems. They vary in range from $1 to $100. And so, like you said, or like in that example, you just can't apply it to everybody.
Yeah, no doubt. So pivoting a little bit, as if all of that wasn't complex enough, there is something that is so important, at least in my world with cancer care, which is, when we say the word accessibility, we mean, can someone that lives somewhere, whether it's financial or not, say they could be like upper class, just doesn't have access to some of the therapies that could treat their cancer in the most optimal way. One of those things being radiotherapy. And then I'm not even going to get into the different kinds of radiotherapy or the competencies of the radiation team, usually all elitely trained, but even the machines matter, et cetera, et cetera. But I see you post often on something that is truly a part of curative therapy for so many things: head and neck cancer, rectal cancer, I mean, just, breast adjuvant cancer. Where do you see AI being or helping the accessibility of delivering radiotherapy in community America, which I know you're kind of a thought leader in?
Yeah, no, absolutely. And I think, listen, vendors and others have made a play on using that word accessible, right? So we want to make care more accessible. But when I look at the concentration of care in North America or in the United States compared to other areas, we have far more for far fewer people. Um, it's what I call it is we have a gross geographic maldistribution of where the care is. Some of that's by design, payer mix. I can tell you now that I'm, just a little bit east of Louisiana, but in Mississippi now, east of Jackson, nobody's rushing to build healthcare right here, right now. And so when we look at like hospital closures in the rural areas, why is that happening? And there's economic factors to why. And in oncology, if we roll back and we use radiation oncology because that's what I know best. But 25 years ago, it was very, very different. The reimbursements were very, very different. And these machines last 15 to 20 years. So many things were done and put in place 20 years ago, and it's different now. The reimbursements have decreased. The machines need to be replaced. They need a capital infusion and investment. The cost of the workers have gone up. This is where CMS got this right as they continue to, with guardrails, expand telehealth and what can be done via telehealth. But then it's the AI part. So it makes me think, where it can start to read the chart, bring that information forward, and then also with direction from that, control some of the machines. So one of the weird things that we're seeing now, and it's almost space age stuff, is CTs and MRIs are now being done without CT and MRI techs. So what's happening is the patient is put on the table by, it could be an MRI assistant. There's programs for this. And then once they're put on the table in the console room, there's nobody there. It's completely taken over remotely by someone else.
That's crazy.
Yeah.
And
So think about it, is right now to recruit physicians, and it's not just physicians, it's clinical workers. Physicians and clinical workers don't stay in practice for 40 or 50 years anymore. They move on. And the data clearly shows that they gravitate towards more populous dense areas. And so that still leaves 20% of the population out. And that 20% of the population's cancer incidence in quote unquote rural areas is much higher. And so you can't leave that 20% of the population out. And this is where AI has to be embraced and where the opportunities are, especially in combination with telehealth.
Yeah, so you're talking about technologies that are able to assist with getting this stuff performed, and I laughed at the beginning on saying how complicated radiation and delivering radiation care can be. Another component of that is when you have the images. I believe it was MD Anderson I heard speaking at one of the larger conferences. They're also looking at how you can substitute the fact that you don't have the radiophysicist available to be able to actually map and design what ends up being the radiation plan, because that in itself is hard to scale and there's a limited resource. So what they're doing is to be able to hopefully deliver, I believe even in third world countries, like life-saving radiation that's not able to be delivered. The curative intent is not able to be delivered at all just because of the absence of a radiation machine and the radiophysicist. Is can we use AI to be able to at least knock off the majority of the dust in the boots and then have a much thinner amount of lift on a specialist to be able to deliver and map these plans. So that's a kind of another part of the workflow where you can see this, improving things.
Oh, it's huge. It's huge. Think about the patient anatomy. So if I have 1 million patients that have undergone radiotherapy and over a 10-year period, and every one of those patients has had a CT sim, and we know that this patient is a prostate patient, this patient is a head and neck. At some point, the anatomy doesn't differ that much. And when you've seen 1 million CTs, to your point, that's where AI comes in and say, okay, you just scanned this patient, overlay it based on the disease site to this library of images. And then what are my parameters as a physician that I want to see? My V20s, my toxicities, protecting small bowel, protecting the heart, and put that in, and it will generate those plans. It will optimize those plans. This is something that's technology is there. It's being used. You're going to see it really push forward over the next 3 to 4 years for various reasons. Third world country regions, like you're saying, but also consistency, standardization reasons. That way we know that this is kind of the gold standard, and now we can assure that. And then also there's financial reasons. To your point, we talked about is we can't recruit some of those heavier weight medical dosimetrists or medical physicists, but the patients in those rural areas shouldn't get any kind of substandard or subpar care. So with the AI being able to supplement that process, I think that's another driver. But that's something that's here and now and being done. So
that's extremely encouraging. Now, one of the things I get asked most often, and I'm sure you do too, is you could give the longest talk on all the ways that we're able to even diagnose diabetes and hyperglycemia just by someone talking into an iPhone. But the first question is, okay, but what about all the the legal liability and who's it fall on, right? And I believe it was you that tagged me or shared the one of the first cases. I believe it was out of Texas where there was an actual case that was relating to the use of AI, or I believe it was a false promise. What are some of the things you have seen or read about that relate to, one, if liability issues are already surfacing to any kind of significant degree, and two, what is our plan for this, and is it sectored off on who's responsible depending on where that use case is? Is it the hospital system? Is it a physician? And what are your thoughts in general?
So it's a rolling plan, right? So like to your point, this is ever evolving, developing. This is not something that attorneys 25 years ago, 30 years ago, would ever have looked at. I mean, right now we all know what a BAA, a business associate agreement is, and likely we're seeing those having to be updated because it doesn't cover AI. It doesn't cover, they want to know, to your point, who owns the data, who's reviewing the data. The easiest thing that comes to mind is every time we get on a Zoom call or a Teams call, somebody inevitably starts that AI note taker. There have been cases already from those AI note takers and things is where is that data going? Because there may be PHI and sensitive information that's being talked about. And so that data is going somewhere and training some LLM being ingested. And so to your point, this is something that, you know, attorneys as well as the government, and that's why you're seeing the government step in and trying to push standardization. And I think the reason they're pushing for the standardization so quickly is to get in front of this because they realize the potential for disaster. If they don't have some level of standardization, the legal liabilities are going to be absolutely incredible because so much is being done, like you said, cloud-based, it's processed. You might have an output, but it's what data, what your data went into the machine to create, and now that's being sold, monetized elsewhere, and you have no idea of what's going on. And so I think it's the life cycle of the transmission of data and the legalities of which points that data is at that carries those liabilities. And that, again, there's whole sectors within the American Bar Association that are now leaning towards AI law and that kind of stuff. So there's a focus in just that now.
Yeah, I mean, outside of even, sensitive data, I've heard questions about which I think part of it is we just need to remind people the examples of when it's already happening. But I say that in relation to examples of machine learning or, deep machine learning that have been around for decades, like are giving us insights if it comes to prognostic or diagnostic tests or, likelihood or unlikelihood of certain things to say, well, how do we know about the machine learning that was behind that? Now, again, machine learning has been around for quite some time. And I think it's the thing that makes people nervous is health and medicine, there's little as intimate, right? Just literally in the biologic sense, and the preservation and optimization of you and your existence. So that is, you could see why there carries a lot of weight, but there's just many different verticals and components that I think are, I want to say interesting or going to be interesting to follow, but I just worry that one big issue or problem could then derail or stall 99 other potential solutions that would help and serve people quickly, because that would be the alarm that was quote unquote necessary to now really take a hard look at standardization and come to some kind of agreement or conclusions.
That's definitely how I see it, is the one red flag will stall process and progress of moving forward. And I think that's going to be a big issue because the potential in my mind far outweighs some of the limitations and liabilities, but inevitably it'll be in the minutia and those fine details of defining those liabilities that will likely slow some of this down.
No doubt. Now, to hopefully talk about some more good stuff, you're somebody that knows well, the kind of new intersection that's happening with people that maybe weren't classically or traditionally in healthcare. Mark Cuban, for example, has talked about, not even talked about, but really taken an initiative when it comes to affordable pricing. Again, I don't know too much about this, pretty much everything about it. But then I hear also, quote unquote Silicon Valley and kind of, tech Goliaths are taking a lot of interest in bringing AI solutions and technology into healthcare. What are some of the things you're excited about or seeing or find interesting that are kind of gnarly to wrap your head around?
Oh my gosh. Listen, just the basics, if they could have mastered it. The UGM was 2 weeks ago, the user group meeting that at Epic, and some of the stuff that they're working on that Judith Faulkner and her team were talking about that they're going to be releasing and working. They're developing their own like LLM inside that comes from all the data that they had inside Epic that's huge. And one of the things it sounds small when I say it, but when you think about the context and how big it actually was, or like the AI scribe, like now it's just like second nature. But if you come up with something like the AI scribe 10 years ago, people would have thought you were crazy. And so, the AI scribe, that development to see where that's going to go. But these big companies, that's why they want in, right? And they toyed with it. So you think of the Aura ring, which I don't have one. I want one. Those things are cool. But you wear the ring and it, gets your health data. All of a sudden, whose data is that, right? So you better believe you're signing a disclaimer somewhere for that. But like you think about all this information, there's shoes that track all kinds of information when you run and that kind of stuff. So I think all of that compiled, as long as it's structured, that's why these people want in. They've Samsung is getting in. All these people, like you said, the big name companies that were really just in tech and stayed in tech, but now they're kind of bringing their ideas over. And I don't think it's a bad thing. I think, sometimes it's good to get a different perspective. And I think they can get us there sooner, but they see the opportunity. I mean, healthcare, when people say healthcare is broken, healthcare is not broken. Healthcare is designed to function exactly how it was designed. And until we crush that design and redo things and mix it up, then it's going to continue to function the way it functions. The problem is, Warren Buffett probably said it best. And so I have had the chance to listen to Warren and the team at Berkshire Hathaway. But what he said was healthcare is a tapeworm, and we continue to feed the tapeworm. And the bigger the tapeworm gets, the more it eats, the more it consumes. And he said the top, the Fortune 10 companies make tons of money off of a quote unquote broken system. So again, it's by design, because if it was fixed, you cut into profits. And I think, to your point, taking it back to the beginning of this conversation, that's where the data, the visibility, being able to see the numbers, and all of a sudden these health tech companies in Silicon Valley, they see that as an opportunity to come in and correct what we internally probably have been saying and voicing for 2 decades.
Yeah. And I mean, maybe to highlight at least some of the financial allure, I believe I read today on the most recent Forbes, top 400, that Elon Musk, obviously a tech person, the difference that he has from him being the richest man to the second place, Ellison, right?
Yep. Larry Ellison.
The difference that Elon Musk has at number one from the second place person, which is Ellison, is more than Warren Buffett's entire net worth. That was a mind-blowing statistic.
Yeah, I mean, those are numbers that are almost hard to even comprehend, right?
Right, exactly.
It's like, how does that even work? Well, and I can tell you, there's so many things working in the background. So one thing that comes to mind is, only because you're from Louisiana, but if you go north in Monroe and then you go east from Monroe on I-20, there's this tiny town called Delhi. Nobody knows where Delhi is. It's in the middle of nowhere. But there's been 3 or 4 Gulfstream jets at Monroe's airport over the past 6 months. Meta, Elon, Zuckerberg, they're building a massive facility out there, and it's already started. They've started to put it in place. So like you said, these guys they're visionaries. They're thinking 10 steps ahead. And they're enlisting people, like you said, others that kind of have that same disruptive mentality. And I think it's huge. I think it's great. And I think it does take money to do that.
Yes.
That's the bigger thing. So I have talked to Mark many times. Know Mark pretty well, Cuban, but Mark's idea wasn't an idea that nobody else had. Kind of like Gary Vee and Uber, right? Lots of people had the Uber idea. Just they were able to execute. Mark was able to execute. He was in a position to execute. He had the visibility. He had the dollars. And so, there has to be those people.
Yeah.
Those people have to exist. And then they enlist others and bring people in to work with them in their vision. So I think that's important.
Yeah, I mean, it takes a Goliath with the means. I believe I read that OpenAI just, made 2 hires to build out their kind of health, investigation and portfolio. I forgot what the gentleman's name is. He's a Harvard grad, and then another female. But all of that to say, if anyone's listening, and you're especially a non-medical person, my Uber driver was actually saying it just today, that one of the biggest frustrations you have in today's healthcare system is it's just a band-aid to the problem, like a pill to the problem. So his wife has, a supraventricular tachycardia, and he's like, but I'm just getting frustrated with doctors because they just say, here's the pill, and nobody tells me the core solution. Part of it is, a lot of it is for a lot of reasons. But one of the reasons, is the reason we got into this reactive philosophy or reactive concept in healthcare is because you come when you have a problem, and it's hard to get to the root of a problem when you only have a couple of data points when there was no problem. And by that, I mean, you're taking a couple of pictures and trying to make a movie, and you can't. Like, that's why comics of, comic designers in 1920s, I'm like, they just sit there and did so many different frames so they could flip that book and make that comic or that picture. That's what was happening is you go get your labs, you get your, x-ray, whatever. And then a year later you get it, right? And then it maybe is 2 or 3 years, and then you have a serious problem, and you're trying to make sense of what happened with just enough data points to capture in one hand. The reason that we get very excited about wearables, for example, is because now you have a continuous longitudinal like movie every day, every moment, when you were sick, when you were not sick, when you had a fever, when you didn't, and when you had that fever, what preceded the week before, what was your heart rate when you went up the same flight of stairs to get, from the parking lot to work. All of these things you can start measuring. And now that you can measure all of this, one can see when you use AI, which the two things that I think of AI as are pattern recognition. At huge volumes, you can recognize patterns and you can predict things. So when you know what ended up happening, but this time, instead of 4 or 5 data points, you have 4,000 or 5,000, you can see the same people that had the same fever or the same flu or the same, intubation that needed oxygen. You can start to see what changed into what standard deviation, how much in advance, to one day hopefully never need a ventilation because your watch is going off, or your ring. Because it's like, this is a 95% chance based on variable of respiratory rate and increased heart rate, to where you'd never need to put on emergent oxygen. So that's where the excitement comes. And it takes multiple things. It takes capture, which like wearables and other things are able to do. It takes, machine learning and potentially deep learning to have to kind of make sense of this objective data. I think a lot of it can be accomplished without deep, maybe, I don't know. And then now that's the preventative world we're talking about. Because you're not going in there to talk about the problems, or when they ask you to your problems, you're going to know about problems that you don't even know you have. That's the key, are the problems under the surface that are present somehow phenotypically, but just not symptomatic.
But that's completely 180 degrees from how all of medicine we built the foundation of medicine, right? And so to your point, this is that, what does it take to overcome this, or how long does it take to unwind? We've been hardwired for this exact system. It's what I talked about. It's not that it's broken, it's functioning exactly. And we're at that inflection point of, okay, now we have these capabilities. Do we embrace them? Do we crush them? And CMS is leaning towards we embrace them. They have, reimbursement now for remote patient monitoring, remote therapeutic monitoring, that kind of stuff. So we are seeing that they're open to this, but it totally transforms medicine, to your point, because there are 1,000 different variables that we can now measure and watch, and not just when we go to the doctor when we're sick, because it's the 95% of the other time we're not sick that we can start to see the symptoms of progression or something happen.
Yeah, like we go to the doctor to find out what pending, sickness or chronic disease or whatever that we're trying to avoid. We're going to get told what our future problems could be without XYZ. And that is wild.
That's crazy. That's wild. That's wild.
Yeah. And you said it best. I like what you said. You're like, what we have is a product, or the system we have today is a product of what we had. And those are the only tools you had. You have new tools. Now, what does the product look like based on what we have today? And that just was never possible before. So it's crazy to think otherwise. Now, where I get stressed out is this, and maybe you're probably the person to talk to about this, is when we start having these predictive models. So take the example of potential, respiratory failure. Take the example of potential precancer, lesions that may pop up, or something that could be cancer down the line, or something that could be diabetes and has a high likelihood. The thing that worries me is the juxtaposition between the way we've always done things, which is we need evidence in a trial to prove, because you need evidence-based, because theory wasn't enough, with the fact that we're not talking about theory now. We're talking about actual like machine learning and deep learning, but maybe not a prospective trial. Does the payer, and I know it's going to be at the end of the day a math problem, is it worth the payer paying for X, Y, and Z based on machine learning models that are coming to conclusions on millions of cases that could end up reducing the cost of treating, terrible diabetic ketoacidosis or stage 4 cancer and stuff. But can we foresee a day when the payers will say, okay, I'm willing to do it now because machine learning and collecting and analyzing all this data is telling me that they're a match for this, big given the past?
The payers will absolutely embrace it. And I think it's just going to take a little bit of time. To your point, everything was, did you make it to a phase 3 randomized trial, and what was the stratification? And we need 5 years of data, and we need 10 years outcome and all this stuff. We've never had the ability to embrace the real-time stuff. Everything has been retrospective analysis, nothing prospective, more looking, other than, you got the BRCA1 gene mutation. We know that kind of stuff, we know. But to have these other 100,000 data points to be able to look at, it's a huge saver for the payers. To the payers to embrace it. And I think that's why CMS has been willing to open up reimbursements for some of this technology and the way it's used, because ultimately what it's going to do is, if I let disease go from point A to point T, the cost at point T is much more than if I let disease go from point A to point D. And if I can get it at point D, it's going to cost me far less to treat it, to cover it. And I think we're still in its infancy. I think once the data, now I do think it happens with pretty swift speed. I think we're in the 5 to 10 years of that happening, that they're definitely going to be looking at it, and it's going to be a strategy for them.
Yeah. And let me try to force an example here. And it's really a beautiful illustration of the concept of precision personalized therapy. We have criteria where we would recommend antibodies for certain viruses, right? Like whether it was COVID back in the day or if it's flu, but you can say, hey, this category of people are sick enough to where the chances are bad enough that something bad will happen to where you're a candidate for antibody, and infusion, or to have what's called empiric therapy. So you take this antiviral no matter what, because we know the outcome could be bad. So sometimes it'll be diabetic. Sometimes, oftentimes it's immunocompromised. And so we have these categories. So if you can understand why we have these categories, often being because that cohort of patients ends up having a greater poor outcome, you're still giving it to 100% of people. So you're catching potentially a lot that wouldn't have had a problem. They just happen to be in that obtuse category. Insert wearables. Now you're talking about objective, data, vitals, where vitals are so telling. Like if you could really see the dynamic change minute to minute. Now we're talking about coverage for a same conceptual thing, which is we know the high risk, but we can have it to a much more precision element, to where those families that are saying so-and-so died or so-and-so got really sick because they didn't qualify for antibodies. Well, guess what? Now, what if your wearable data actually was able to show or demonstrate that you were that high-risk patient? So you're getting to capture all the people that don't fall into a category that still have a bad outcome. Yep. And you're getting to spare the toxicities of unnecessarily treating, because they're in that category and their likelihood was high, even though it is never, 95%, but just because it was higher than the norm. And I think these kind of things would be very interesting. And it's always, I take a breath of fresh air, or at least a sigh of relief rather, when the money adds up to improve patient care, because I know that has your path of least resistance.
No, right. Absolutely. And usually the case is, this is going to cost a lot of money and the benefit's not very good. In this case, it may not cost a lot of money and the benefit is massive. And because, like you said, it's just a huge number of data points that we're able to track and apply, and then be able to have those sectors based on this data. And even if we collected that data for however long, 5, 10 years, the predictive capabilities are incredible.
So on that note and the excitement, and you're saying, you absolutely believe that payers will do that, because obviously it makes sense from a cost effectiveness and for what you and I care about, patient care and patient outcome. Can you explain to me, I guess somewhat briefly, but how that's not almost like today's value-based care models, right? Because if you're getting and crunching data to be able to say, even if the point of entry has to be cost effectiveness, isn't that what a value-based care model is today? The thing that says we're going to go a little bit against the standard stuff because we think that this will lead to better care and actually less costs, or am I totally off base here?
That's exactly what it is, as a matter of fact. I mean, the problem is value-based care today and in context. The issue is 99% of value-based care is still 99% dependent on volume and RVUs and that system. We've tried to get away from it. We've tried to incentivize, and they've really struggled. I mean, CMMI had tons of models on value-based care, and it was like fail, 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 abandon, abandon, abandon. But with this data and what AI has the capability to do, it may be what bridges the gap to an effective value-based care, because it's AI and everything that we're doing, and what the potential is, and for them to cover, it's a different flavor. It's still value-based care, but it's a different flavor of value. But this may be one that actually works, because everything up into this point has been a way to redirect fee for service and that kind of stuff, and seeing CMS embrace and payers embrace reimbursable events, CPT codes. CPT or volume, they're volume based, right? So now they're kind of blending. Okay, we're going to pay for this, and so I think that may be the path forward for sure. But it's not new, just repackaged with a different bow on it.
Exactly. Yeah. I mean, it's the newer thing that is based on what we have, like what you keep saying. Like it's the updated version that mirrors or is parallel to what we're able to capture and crunch and analyze.
Value-based care 3.0, man.
That's it. That's it. So Jordan, I cannot believe we're already at 50 minutes. We're going to be talking both at AVBCC. I can't wait to be on that panel with you. You got a great group with Deborah Pat, and Doug Flora and many others. What are some of, I'm sure you're speaking at other things. What are some of the things you're most excited about just in general, or most optimistic about when it relates to healthcare, having seen things from your law degree to your operations, to your workflows? What are you excited about most? Give me one, you can give me a couple.
Probably the most exciting is the ability overall to save time, because that really is the issue, is save time, but not just from redundant tasks, save time to then refocus task. Because we are in a situation now where med school is the same way, but all clinical roles and responsibilities are on their head right now. We've staffed hospitals. Like I said, it's not broken. It's functioning the way it's always been, but we staff healthcare facilities and hospitals from 7 to 3, 3 to 11, 11 to 7, 3 shifts. Guess what? A lot of people want to work part-time. They want to work PRN. They want to work, 3 days a week. All that is real and happening. How do you do that? And it's the data drives that. And with supplement from AI and technology, that becomes possible. And so I think that's what I'm most excited about, is the pain forces innovation. Either you fail and stop and quit, or the pain of some of these scenarios. And I think that's what's driving a lot of our innovation right now, is that pain.
Well, Jordan, it's been a real pleasure. This literally is probably my fastest podcast hour, just because I could ask you a million questions. So we appreciate you. And is there anywhere besides LinkedIn you must follow if you're interested in this stuff at all, that we can have everyone, find you, conferences and the like?
Right now, LinkedIn, AVBCC in the fall. In October, we've got Astro coming up for radiation oncology at the end of the month. Got a couple of ABA meetings, so the fall will be busy, but tune in.